Welcome to Imaging and Physiology, Part 3. We have very exciting session with a lot of different topics. I am I.K. Jang from Massachusetts General Hospital, Harvard Medical School, Boston. With me is Dr. Alan Jamoraya from St. Francis, New York. We have panelists. We were supposed to have 5, but we had 4. An Jung-min, 선생님, and Akiko Mayahara, and Hitoshi Matsuo, and Frederick Zimmerman. The first session will be imaging, and second session will be primarily physiology. So the first speaker, unfortunately, won't be able to join us, but he recorded his talk. Vulnerable Plaque Imaging, Old and New, 2022, Dr. Onuma.
Today, my topic of presentation is Vulnerable Plaque Imaging, Old and New in 2022. I would like to thank the organizer to have me in this important session. Just to back on the basic concept of vulnerable plaque, the concept of the vulnerable plaque was initially defined by the Professor Jim Mueller in 1989 as a plaque at increased risk of thrombosis. Since then, the search for the precursors of culprit plaque underlying acute cardiac events has been the subject of the multiple investigation using a different type of the imaging modalities. And actually, what we are looking for, so from the pathological study, we know that thrombotic lesion is caused by majority of the case rupture of the necrotic core in 60%, and precursor of this necrotic core rupture is the thin cap fibroadenoma. So this is really the major target for the imaging. But I must also say that 30% of the event is also related to the erosion. Approximately 5% is caused by the calcified nodule. So the precursor of this erosion or the calcified nodule could be something different from the thin cap fibrous fibroadenoma. These are the imaging modalities available in cath lab or clinical settings. Ivis, OCT, near spectroscopy, Ivis are the 3 major modalities in the cath lab for the intravascular imaging. We also have CT angiography as non-invasive imaging. So what we have learned from the early studies like the prospect and prediction, of course, the prospect was the first natural history study. They identified that the plaque burden of equal or greater than 70% thin cap fibroadenoma at that time measured by the partial histology and MLA equal or less than 4.0 square millimeter are the important parameters to predict the future event. If the patient has 3 parameters together, then the event rate is as high as 18.2%. The near spectroscopy Ivis study also showed that if the patient has a high LCBI index, then those patients has more likely to have a future event. Recently, from 2019 to 2022, the series of the studies was published to confirm those results again to demonstrate that the intravascular imaging is really able to detect the vulnerable plaque. So LRP study is one of them, enrolling 1,563 patients from the 44 medical centers, and they look at the baseline LCBI and the clinical event. So this study clearly demonstrates that if a patient has a max LCBI 4 millimeter greater than 400, those patient has higher future event. And adjusted hazard ratio for the non-culprit lesion later MACE was 2.18, and it remained to be the significant even after adjustment, and the ratio was 1.89. So this study clearly demonstrates that the near spectroscopy Ivis could identify the patient and segment at higher risk for subsequent and MC MACE. Prospect 2 was also the very large study published last year in Lancet. The patient was with the recent myocardial infarction. After successful PCI, 3 vessels were examined by the Ivis and near spectroscopy. Those examination was performed in 898 patients. This is one example. There's a non-obstructive plaque in right coronary artery with a very high plaque burden and a very high max LCBI of 687, and this patient had the event day on the almost 3 years later. So in these studies, the two parameters was identified. The one is a max LCBI for millimeter greater than 324, and the other one is based on Ivis plaque burden greater than 70%. If the patient has the both these high risk features, large plaque burden by Ivis and large lipid-rich cores by NIAS, then those patient has a very high event rate of 13.2%. So those studies demonstrated the capability of the NIAS spectroscopy Ivis to identify the vulnerable plaque. But what is the treatment? So the prospective Absolve trial look into that aspect of treatment. So they random the patient with this vulnerable plaque on imaging into the Absolve arm or the medication alone arm. They also demonstrate that this approach was safe and substantially enlarged the follow-up MLA and potentially associated with the trend toward the favorable long-term outcome. Indeed, there was no significant event difference in event rate, but there was some trend toward the favorable outcome for the Absolve arm. CLIMA study looked into the OCT parameters and the clinical event. They identified the 4 parameters: MLA less than 3.5, fibrous cap thickness less than 75 micron, lipid arc greater than 180 degree, OCT defined macrophages. So if the patient has those the 4 parameters, so the patient has almost 7 times higher risk of the patient who doesn't have those parameters. So the event rate on those population was 18.9%. Combined FFR OCT study was specifically looking into the diabetic population with a vessel which has a negative FFR. FFR value was greater than 0.8, and in those vessels they divide the population into two groups based on the Ctffr detected on OCT. So if you look at the Kaplan-Meier curve of those population, you see that the OCT Ctffr arm population has a higher risk of the future event. Among these diabetic patients with FFR negative lesions, the Ctffr positive patient represented 25% of those population and were associated with the 5-fold higher rate of MACE despite the absence of ischemia. In a sub-study of the prospect study suggested that we can also improve our prediction by using plaque structural stress with a sophisticated analysis. So these are the summary of those event and parameters and negative predictive value and positive predictive value. But I think the 2 important parameters now is the max LCBI per millimeter and plaque burden demonstrated by in the lipid-rich plaque study and prospect 2. And prevent is also very important to shed light on the treatment of those population. And the OCT also demonstrated significant prognostic importance, especially for the Ctffr or the other parameters. So what will be the future of the intravascular imaging? Probably the combined catheter could further improve our diagnostic or the prognostic prediction capability of the future event. Ivis OCT hybrid catheter is available. This is a CONAVI system which is already available in human. Terumo also developing the Ivis OCT hybrid catheter, and I must say that also the Professor Jim Mura is and his colleagues and the group are developing the OCT NIAS imaging for detection of coronary plaque structure and vulnerability. So these are the timeline of development in future directions. We should also look into the CT or the non-invasive imaging, because the intravascular imaging is appropriate for the patient who had established CAD or who had already event. But for the primary prevention in patient who doesn't have previous event, the non-invasive imaging such as coronary computer tomography angiography might be more suitable to identify the patient with elevated risk. So those are what we can measure in MSCT. So you can look at the lumen, you can of course look at the plaque characterization, calcium, you can also look at the CT perfusion, ischemia, FFR CT, And recently, the perivascular fat is identified to be very important prognostic factors. So the plaque characteristics such as napkining sign, low attenuation plaque, positive remodeling with spotty calcium is also has a significant prognostic factors, and these studies show that even with without significant obstruction, these adverse plaque characteristics such as positive remodeling, spotty calcification, low attenuation, has those patients has really the worst outcomes. Again, the low attenuation plaque burden seems to be also prognostically important, and that was the most strongest predictor of myocardial infarction in this study. Previously, the group of Professor Ko also demonstrated the adverse hemodynamic characteristics such as the delta FFR CT gradient over the lesion also has prognostic incremental value for the prediction of the event. Perivascular fat is a new parameter. Initial cohort validation cohort published in Lancet clearly demonstrated if you have an inflamed fat around the coronary artery, those patients has worse clinical outcomes. And recently also another cohort, another study demonstrated the right coronary artery, the perivascular fat CT attenuation is the pericoronary adipose tissue CT attenuation has a significant value in terms of prognosis, 2.84, together with the volume of the non-calcium plaque. So those are the important factors for the risk stratification. So as a conclusion, the new trial data such as the LRP or the prospective demonstrates the near spectroscopy Ivis are able to identify the high risk vulnerable plaques and leading to future event. Plaque burden, LCBI 4 mm, max 4 mm is important parameters. Prospective absorb demonstrate the feasibility and safety of the local scaffolding of imaging detected vulnerable plaques. This approach will be further being evaluated in the PREVENT trial. We should really know that how to treat those elevated risk plaque. OCT study also demonstrated that OCT detected parameter could be associated with the higher event rate. And I think non-invasive imaging with the coronary CTA offers a potential as a screening tool to identify the plaques and patients with the elevated risk. And parameters like high risk plaque characteristic, non-carceral plaque volume, adverse hemodynamic characteristic, and perivascular fat seems to be very important factor for the prognosis in CT. Thank you for attention.
Thank you so much. That was a fantastic overview and I think a great start into the session. We're going to have a panel discussion at the end, so we're going to move through the talks. And next up is IK talking of vulnerable plaque research. IK.
I hope my talk is not too provocative. It's almost opposite view of what Dr. Onoma said, but I will try anyways. It doesn't. Okay, this is my disclosure. So Einstein's definition of insanity. Hold on, it doesn't. So doing the same thing over and over again. And expecting different result. So what does Einstein's definition of insanity have anything to do with vulnerable plaque research? So Steve Nissen wrote this a couple of years ago. It seems abundantly clear the entire concept of vulnerable plaque is fundamentally flawed and reflects an overly simplistic view of the pathophysiology of underlying coronary event. To date, proponents of vulnerable plaque imaging have not conducted high-quality trials, and no imaging modality has yet demonstrated meaningful clinical benefit. After thousands of vulnerable plaque papers and more than 2 decades of research, we have little to show for those efforts. Steve and I don't share everything, but as far as vulnerable plaque research is concerned, we're on the same page. So the preconception of vulnerable plaque, this is what I was thinking too 22 years ago when I studied OCT. Find the vulnerable plaque, treat it, prevent ACS, sudden cardiac death. Very simple. So most ACS, as Dr. Onoma said, are triggered by plaque rupture. Most ruptures occur at ThinCap fibroatheroma, and therefore identifying Ctffr confers high-risk ACS. Treating Ctffr with stents prevent future ACS and sudden cardiac death. Very simple. It's a level of grade school, maybe second grade. Human biology is not that simple. Let me try to convince you that's not really the truth. So I will try to explain very simple, short way, and these 5 facts. Atherosclerosis is a panvascular process, and plaque phenotype constantly changes. And 3/4 of plaque actually do regress with contemporary medical therapy. And subclinical plaque disruption and healing continuously occurs. And plaque erosion, as Dr. Onuma said, is responsible for 25 to 40%. So this is a study that we published almost a decade ago. We look at the plaque phenotype, plaque characteristics of non-culprit plaque, and compare the characteristics between patients presented with ACS against patients presented with stable angina. So these are the non-culprit plaque characteristics: red box ACS, yellow non-ACS, so stable angina. So the non-culprit plaque of the patient presented with ACS had greater lipid burden, much thinner fibrous cap, and therefore much higher prevalence of Ctffr. So this is a panvascular inflammation. And plaque phenotype changes. This is a study by Takashi Kubo and Gary Mintz. Let's just look at the second group. VH Ctffr, after 1 year of treatment, 3/4 become stable. So if you were to treat VH Ctffr only because you think it's going to cause something, 3/4 of people would get unnecessary treatment, unnecessary stent. With contemporary medical therapy, this was a study that we published a number of years ago. So very aggressive protocol, baseline Ivis, 6-month Ivis, 12-month Ivis. About 3/4 of plaques, it's a plaque-based analysis, do not progress. They actually do regress. Plaques get smaller. Not only plaque composition changes, but plaque volume changes. About 10% slow linear progression through proliferation. About 25%, there is rapid stepwise progression. That's a plaque disruption healing process. About 10% early rapid progression, 5% late progression. How can we stabilize these high-risk vulnerable plaques? Among those 4 or 5 components of vulnerability, if I were to pick one most important predictor, it's going to be fibrous cap thickness. So it was a prospective randomized study we did. So 3 times fibrous cap thickness. This is OCT 3 times. So with 60 milligrams, it was done in China. So that was the highest dose approved. After 6 months treatment, fibrous cap thickness became 61 to 142. After 12 months, tripled. So very unlikely a plaque, lipid-rich plaque with fibrous cap thickness, 180 will easily rupture. Even low-intensity statin reached the double after 1 year. So slow, less robust response, but they do the job. So subclinical disruption, atherosclerosis is a process of continuous plaque disruption and healing, which has been shown to be present in 73% of autopsy studies. But that's not new. And in recent few years, it happened to be all the fellows from Italy in our laboratory. They studied this healed or layered plaque. And this healed plaque was present in 50% of people with stable angina and over 25% of people with ACS. So it's a balance between plaque vulnerability and endogenous protective mechanism. So as Dr. Onuma said, plaque erosion is responsible somewhere between 25 and 40%. So even though you have a perfect tool that can help us to identify a plaque that's going to get disrupted, you will still miss 1/3 of the people who are going to develop ACS or sudden death. So just quick introduction of everybody knows Prospect trial. The MACE rate was 11.6, but 0 mortality, 1% myocardial infarction. What drove this endpoint was all revascularization, okay? So these are three predictors: plaque burden more than 70%, VH Ctffr, minimal luminal diameter less than 4. So plaque burden, plaque burden. So what's the definition of VH Ctffr here? Plaque burden 40% and absence of visible fibrous cap. So plaque burden, plaque burden, plaque burden. So when you have a greater plaque burden, it is to be expected at some point it will come to the critical level, which will cause imbalance supply demand. And they will develop angina revascularization. So plaque burden is what dictates future event. Our friend Armin Zadet from Johns Hopkins University did very smart analysis from Prospect database. The risk of MI and cardiovascular death. This is what we are talking about when we talk about vulnerable plaque, not revascularization, not stable angina. The risk of combined MI and cardiac death, Ctffr by VH Ivis, and intimal hyperplasia, same. So what do you think is dangerous, VH Ctffr? The risk is comparable to the risk of intimal hyperplasia. So the take-home message from Prospect trial is potential risk of MI combined STEMI and non-STEMI. If you do STEMI, it's even worse. From VH Ctffr is 1%, which is similar to that from intimal hyperplasia, which you see everywhere. And plaque burden, as opposed to plaque phenotype, is an important factor for development of recurrent ischemic event, not ACS, not cardiac death. We look at our MGH database, 1,500 patients, 500 had lipid-rich plaque, and not anywhere, just that particular lipid-rich plaque after 4 years caused STEMI in 0.4, and we look at even higher subset, Ctffr, 0.6%. So if you were to treat Ctffr only because you saw it on OCT, you are not doing good medicine. So conclusion, this is conclusion of my talk. The concept of vulnerable plaque needs to be revisited. Atherosclerosis is a panvascular process with repetitive plaque disruption and healing. And over 3/4 of atherosclerotic plaques stabilize with contemporary medical therapy. And plaque erosion is responsible up to 40%. So I wrote this a couple of years ago. The absence of natural history studies, the invasive nature of current diagnostic modalities, effective contemporary medical therapy, and erosion contributing up to 40% of ACS make vulnerable plaque research a major challenge. Thank you.
Thanks, IK, for this provocative talk. Very, very interesting, and I'm sure it's going to be fostering interesting discussion later on. Why don't we move on to the next speaker and some of the practicalities of imaging. My partner and colleague here at St. Francis, Ziad Ali, on the interpretation of intercurrent imaging for PCI. Ziad?
All right, so we're shifting gears from the heavy-duty sort of next revolution to really the basics of interpretation of intracoronary imaging for PCI. These are my disclosures. So first of all, we need to understand the normal artery morphology before we can really understand intravascular imaging. And the reason for this is over recent years, there's been a significant increase in the resolution of all the modalities, which actually allow us to see these layers. But to understand them, we really need to make them analogous to something that we are familiar with. So the intima, and I'm going to show you this next, is something like a scoring pad. The internal elastic lamina is a rubber band. The media we're going to think of as a dense sponge. The external elastic lamina, which is here, is another rubber band, and the adventitia is going to be considered to be a mesh. So why do we make these analogies? Well, actually, if you think of the top of a scoring pad, it's actually very haphazard. The cells were not there naturally, so they're not organized in any specific way. And actually, this is a remodeling process that occurs, and as a result, the intima is actually quite tough. Contrary to popular opinion, the media is much softer, has much less tensile strength, and is actually like a twined rope, such that if we were to split the media, it would split very easily. Those of us who do CTO-PCI understand this phenomenon. The external elastic lamina is in fact a membrane made of elastin, so it has elastic properties. And finally, another thing that's not really well established, I would say, is that the durability of the artery really comes from the mesh or the adventitia, where 70% of the tensile strength of the artery is held. The reason this is important is we can see these layers, the intima, the internal elastic lamina in red, the media or the sponge in black, the external elastic lamina in green, and the adventitia outside in mesh by OCT, which is where we're going to start. Now, in order to make image interpretation practical and usable, we need an algorithmic approach. And the simplest way to do this is to ask yourself on any cross section whether you're able to see the rope or a mesh, and that is the EL and the adventitia. If you are able to see it, the artery is either normal or it's fibrous. But if you're not able to see it, and there's a signal change in the lumen or the wall, you have to ask yourself whether it's in the lumen, in which case it can be high attenuation, or it can be low attenuation, or it can be in the wall. Again, it could be high attenuation or low attenuation. Now, the concept of attenuation is not so simple, or in fact, it is simple. To make it simple, what happens when your high attenuation is, imagine we take a bowling ball and place it floating in front of a flashlight. All of the light behind the bowling ball will be blocked. That's high attenuation. On the contrary, if you take a crystal ball and shine a light through it, the light will refract or bend. And this is the same properties that we need to understand OCT imaging. So here's a flashlight that basically goes through everything. There's no refraction of light. The artery is normal or fibrous because you can see both the EL and the adventitia. Similarly, although there's pathological intimal thickening on this cross-section, we are able to see the mesh and the rope, the EL and the adventitia, and as a result, there is no attenuation of light. But now we start to see that there's a problem. We're able to see the mesh and the rope from 12 o'clock to about 8 o'clock, but from 8 to 12, there's a dark signal attenuation. The attenuation is in the wall, it's high attenuation, and that is lipid. Here's another situation where there's an attenuation within the wall, but in this situation, it's low attenuation. You can see the light is hitting something, but you can also see that the light rays are spraying afterwards or refracting at the distal end of this calcified segment. When we have a problem that's in the lumen and it's high attenuation, this is red thrombus, so there's complete inability to see the wall behind it. And when there's a signal change within the wall and we are able to see behind it, this is low attenuation, and that is white thrombus. So as a result, we are very easily able to use an algorithmic approach to determine the vast majority of information that we need to perform in order to do pre-plaque analysis for PCI. Following PCI, we need to understand the different types of dissections: intimal, which tear into the sponge or into the scoring pad; medial, which tears into the back end of the sponge towards the external elastic lamina. The reason this is important because, of course, it can create an intramural hematoma. We need to understand that apposition is simply the lack of touching of the metal onto the wall of the artery, and only proximal malapposition interferes with stent outcomes, possibly due to reintervention. Tissue protrusion is the presence of the sponge sticking through, whether that's sponge or thrombus sticking through the stent struts, and really only matters if we are impacting more than 10% of the flow area. Let's move on to Ivis. The first question with Ivis is there plaque? If there's no plaque at all, the artery is normal. If there's plaque within the lumen or the wall, then we know we have a problem. And we again divide it into lumen. And if it's hypoechoic, it's chronic thrombus. If it's hyperechoic, depends whether there's shadow. With no shadow, it's acute thrombus. With the shadow, it's calcified nodule. Shadow will also always lead to the presence of calcium. In the wall, if it's hypoechoic, it's lipidic. If it's hyperechoic and there is a shadow, it's calcium. With no shadow, it's fibrotic. And like I showed you on OCT, current generation 60 megahertz Ivis is actually able to show you these layers of the artery with great resolution. We're going to use the same analogies in this situation. But to really understand Ivis, instead of thinking of this like light, like we did for OCT, we need to think of this how sound behaves in common life. So when something's hypoechoic, we would take the analogy of yelling into a pillow. All of the sound would be absorbed. On the contrary, hyperechoic would be getting an echo in your basement, and the sound is reflected. So in this situation, there's no reflection because there's no plaque, normal artery. Now in this situation, there is a problem within the lumen. It is hypoechoic, meaning it's absorbing sound. You can see that there. The sound is absorbed. This is chronic thrombus. Again, there's a problem here within the lumen. In this situation, it's hyperechoic. It's not absorbing the sound. It's not dark. It's reflecting the sound. And as a result, this is actually no shadow, acute thrombus. When we have a signal attenuation within the lumen and it's hyperechoic, here, the sound is being reflected and there is a shadow, this is a calcified nodule. When we have a problem that's within the wall and it's hypoechoic, again, you can see loss of signal, dark signal within the wall. The sound is being absorbed, and this is lipidic plaque. On the contrary, when we see a signal within the wall and we're actually able to see the media without any loss of signal, it's hyperechoic. This is sound reflected. There's no shadow, and this is fibrous. And finally, when we see that there is indeed a problem within the wall, it's hyperechoic. The sound is reflected. There's a shadow behind this segment. This is calcium. So you can see in the last 10 minutes or so, we've been very quickly able to use an algorithmic approach to understand and interpret intravascular imaging for contemporary pre-PCI planning. What about post-PCI? Here you can see very easily a malapose stent, which is basically the stent floating away from the artery wall. This is an example of a dissection where the artery wall is taken away. You can actually see there's a blood speckle between the media and the intima, so the area that's going to the external elastic lamina. And an underexpanded stent, clearly you can see that the artery is much larger at the distal stent edge, but there's an area where the lumen has not expanded. So using an algorithmic approach to image interpretation can really simplify what seems complex. The fundamentals of OCT are based on the principles of light attenuation. The fundamentals of Ivis are based on the principles of sound. Practice makes perfect. Thank you very much.
Thanks, Ziad. Nice job, as always. And why don't we move to the last session, or last lecture of this session before we have the discussion. Dr. Kang, more practicalities, if you will. How do we actually implement all of what Ziad was talking about in our everyday cases in the lab? We can see your slides. Go ahead.
I'm Dr. D.Y. Gang from Asa Medical Center. Today I will talk about when and how to use the intracoronary imaging in my cath lab. I have nothing to disclose. When do I use the intracoronary imaging? That was the first question of the lecture topic. The first is to guide PCI. In Asa Medical Center, we think that we are imaging and physiology centered cath lab. We have 4 cath labs for coronary procedure and perform about 6,000 CAG and more than 2,000 PCI per year, and use more than 2,000 intravascular imaging per year, and also about 1,700 FFR per year. Then the intracoronary imaging penetration rate for PCI guidance in other medical center was more than 95%. Why do we use intracranial imaging in almost PCI cases? I think that there are two fundamental questions for interventional cardiologists when performing a PCI. First would be the question that is a lesion significant, ischemia producing, and should it be treated? Second would be has the PCI been optimized? For the first question, the physiology can give answer. And for the second question, imaging can guide to optimize my PCI. This is the report from the ODF-DS study that after Ivis use, procedure changed in 74% of the procedure. And the major change was the change of the larger and stent balloon size with a higher pressure and longer stent, and also additional post-dilation was performed with Ivis. With this lower of the Ivis, there are tremendous data from the registries and RCTs, and these two are very important two RCTs with the long lesions, Ivis XPA, and all common patient ultimate RCT. All two studies showed a long or 1 year clinical, also 3 or 5 year clinical benefit in clinical outcome. Also, Ivis use was associated with a better 10-year outcomes after left main PCI in main compare registry. With this data, the current PCI guideline recommends Ivis as a 2A recommendation for procedural guidance, particularly in cases of complex PCI, and OCT as a reasonable alternative. So I can answer why do we use intracorneal imaging in almost PCI cases? Because we believe that the imaging guidance improves the patient outcome, especially in the complex PCI. Then, when to use intracorneal imaging, more than to guide PCI, one will be to find the cause of acute coronary syndrome without clear culprit, sometimes with the erosion or SCAD. And another indication would be to find the vulnerable plaque. But as Dr. Onuma and Dr. Zhang pointed out, it is only research-based yet. And we performed the PREVENT trial with a significant coronary stenosis without FFR significant, with the vulnerable plaque defined by the Ivis or OCT. We performed preventive stenting versus optimal medical treatment. And the enrollment was completed last year, and we would give answer about the vulnerable plaque treatment next year. And for intracorneal imaging use to find functionally significant lesion, some centers use intracorneal imaging for this purpose, but in our center we do not. Because in our data, Ivis guided minimal lumen area was not well matched with the FFR in non-left main disease. There was the positive predictive value was very low. In left main, there was some higher degree of the predictive value and sensitivity and specificity, and the cutoff value was 4.5 in our data. But still, we do not routinely use the imaging for defining the significance of the lesion. We just measure the FFR. So that is the first question, and now move on to the second question. How do I use intracoronary imaging for PCI guidance? The role of intravascular imaging for PCI guidance would be to optimize acute stent result. For that, the first is to assess the plaque characteristics and perform adequate pre-modification. Dr. Ali well showed how to interpret and how to prepare the PCI with the imaging. And then, especially in case of the calcified lesion, we should check the intracoronary imaging and confirm the result of the plaque modification. And Dr. Akiko Meara showed a very beautiful calcium scoring by intracoronary imaging that well predicted the stent expansion rate after stent. So in case of the high risk of the stent under expansion with the intravascular imaging-based calcium evaluation, then aggressive plaque pre-modification would be needed. And the third would select the clean landing zone that defines the stent length and assess the vessel size and select the larger stent as possible. In our previous DS registry data, the best cutoff of the edge-risk stenosis was the plaque burden. Lower plaque burden was the predictor of the less edge-risk stenosis. And also, effective stent area more than 5.0 square millimeter was the predictor of the low TLR. So make the good landing zone and make the stent expansion rate more than 5.0 would be the key for successful PCI. Also in left main PCI, we show the data that the bigger lumen area was predictor of the good event-free survival after left main PCI. So achieving larger lumen area with Ivis guidance or OCT guidance can make good clinical outcome. And then after stenting, evaluation of the imaging or not, select a larger sized NC balloon for post-dilation is the key for successful procedure. In our Iris DS registry data, a total of 9,000 patients with a single complex coronary lesions like left main, bifurcation, diffuse lesion, calcified lesion, ISR was selected when selected. And we checked the primary outcome with a composite of cardiac death, target vessel MI, and TVR. And we've defined the imaging-guided PSP as the proper imaging-guided PCI procedure. Predilation with the Ivis guidance and stent sizing by imaging, and post-dilation with the surveillance of the stent outcomes would be the key steps for IPSP. The patient with the IPSP had a larger stent number, longer stent length, and larger stent diameter. Also, the final balloon size was significantly larger in imaging-guided group. And the primary outcome was significantly better in all patients and even after aggressive statistical matching. And the post-dilation was the most significant event predictor among 3 components of IPSP. As you can see in this table, the patient underwent Ivis imaging, had the larger post-balloon size compared with the stent diameter. But the patient without Ivis used the post-balloon size similar with the stent diameter. With the imaging guidance, we could apply larger and higher pressure NC balloon after post-dilation, and that was the key for better clinical outcome. And finally, after post-dilation, post-stenting surveillance for good stent expansion and edge problem, as Dr. Ali showed where, would be the key for optimizing PCI. With intravascular imaging, I can implant bigger stent and higher pressure post-dilation safely with the imaging guidance. And that small details during the procedure make a big difference for clinical, long-term clinical outcome. This is an example of the intercurrent imaging for optimizing PCI. And I'm pushing the predilation and the Ivis. This is and checking the Ivis. And then, after then, I'm talking with discussing with my fellow. The important thing is that someone is measuring the Ivis. Someone is evaluating and measuring with discussing with me. Who is he? He is the important personnel. We have the operator and my fellow and technician, and have the technician that was well trained for intravascular imaging measurement. And I believe that he is the key man for successful imaging guided PCI. The operator can measure it by myself, but it's some time consuming, and sometimes it can be some inaccurate. And I believe in our center, the key for successful and fluent imaging guided PCI would be the education of cath lab professionals for measuring and assessing the lesion of the intravascular imaging. And the final question, which imaging device do I use? There is some difference between OCT and Ivis, and the OCT shows better actual resolution but needs contrast, and Ivis shows good penetration depth and shows the better in ostial visualization and vessel visualization. And in this, my practice, main or ostial lesion, I prefer Ivis. Bifurcation was better. Long lesion, OCT saves time, but Ivis also can save time with a faster pullback. For CTO, Ivis I prefer, and OCT, ISR in ISR, IOCT, I prefer OCT. And to solve the question, to answer the question, we performed the Octaves trial of pragmatic RCT comparing OCT versus Ivis guided PCI in all Pci. And we completed the enrollment this year, January, and I will be able to answer the question next year. And in conclusion, intracranial imaging guided PCI is the evidence-based approach for the best clinical outcome. And imaging enables safe and effective PCI with a larger stent and balloon, resulting in a larger final stent area. Team education is important for procedural fluency in routine use of imaging, and practice makes perfect. Routine use of intracorneal imaging would make perfect PCI team. Thank you for your attention.
Thank you. Nice job. So why don't we move into the panel discussion? I think all of us are obviously imaging enthusiasts, and I would venture to say that the vast majority of us are using this more or less routinely in every PCI. Maybe the more controversial topic this morning is how to deal with vulnerable plaque, right? I thought Ike's talk was very provocative. Do we have the tools to get the imaging right? Do we have enough evidence to know how to treat it? And so maybe let me throw out the first question to Akiko, who obviously is intimately familiar with this topic from the CRF core lab, looking at thousands of these imaging in various trials, including Prospect. Akiko, do you think we have enough to go by at this point to, number one, have the right tools to get the imaging right, identify vulnerable plaque, and two, what should we do about it?
I think should we enough or not? Most likely. But by the way, I do agree, Dr. Ikenjan, completely, meaning that we learn a lot what is a vulnerable plaque by intravascular imaging, but we know the patient actually doing super well. So ultimately, where we should go is really primary prevention cohort by looking at the non-invasive technique and then using our knowledge, what is important of the vulnerable plaque by learning the intravascular imaging, such as plaque burden, repeat-rich plaque, that's making the transition to the primary prevention cohort. That's, I think, our goal. So I think, are we ready to go? I think almost, meaning that we have a step-by-step study from the almost 20 years ago to now, and we really confident plaque burden is important and repeat-rich plaque is important, but only thing which we don't know is what is the prediction of the plaque erosion. That's only thing which we don't know, but I think the next step is, because we did already somehow feasibility study in the prospect of SOAP, so how can we do if we do more aggressive study? I think we are getting close.
Akiko, if I can ask you a question, in Boston, we are far from industry. So there are several companies, more than several possibly, trying to develop intravascular diagnostics to detect vulnerable plaque. What's the end goal? I mean, is it something that we should support?
I think so. I think
as academic physicians.
Yeah, I think the current issue of the vulnerable plaque is viability of the imager, meaning like if I answer, this could be Ctffr, but if my fellow answer does not be Ctffr. But those companies trying to make more robust or easy to understand or almost like algorithmic approach, meaning if turn on the picture, you see this is vulnerable plaque point something. So they try to make it more easy. And that's, I think, important to do.
Alan, if I can, so it's interesting. I shifted my opinion on this multiple times. Firstly, I was a total non-believer. I said, this is bogus. If you have a negative FFR, your chance of having an MI is way less than 1%. And then I read every angiogram in Prospect 2 and every angiogram in ischemia. And I think the problem is you cannot have a vulnerable plaque MI in 1 year. These take forever. How can an atherosclerotic process that starts when you're in your 30s and 40s and manifests in your 70s and we have a 1 year endpoint? It will never work. We need longer endpoints. I actually do believe that vulnerable plaque exists. I believe the vulnerable patient exists. And maybe that method is going to be to look at CT. It might not be what we think, but that's where I think we're going.
Yeah, I mean, to Ziad's point, I
of,
think if the endpoint is more than 1 year, you know, stenting, I think, is not the answer, right? Because you're going to create a whole new, you know, potential slew of problems by placing a stent. It can only be medical therapy if we're trying to prevent something that happens years down the road. But let's talk from a practical standpoint. Young men, let's say in your practice, when you image, right? You guys image routinely. I would imagine you image not to see vulnerable plaque, you image to kind of plan your procedure and figure out, you know, where to land your stent. But let's say in that process of doing so, you would see some vulnerable plaque. How do you respond to it in a vessel where you're already planning to do PCI? Would you extend the stent? Would you try to not, you know, land your stent edge in it, or does it not matter and you just proceed as always?
Thank you for very important questions. First of all, I do not use in my practice. I do not use intravascular imaging to detect the vulnerable plaque. Instead, as you mentioned, that I used the intracurrent imaging to optimize my stent result. For example, my stent landing zone, there is some plaque. I like to avoid the vulnerable plaque on my stent landing zone. So I put the longer stent longer than my initial plan. So Ivis guidance may implant a longer stent and larger number of stent number, but based on the Ivis findings, I think the intracurrent imaging makes us the more optimized stent result, and then resulting in the better clinical outcomes in the long term.
So, but let me throw this up, maybe to Fred. I don't know what your practice is and how frequently you're using imaging, but is imaging mandatory in every case, or should we try to confine it more to the more complex cases where we know the benefits, at least the you know, cost benefit certainly is favorable, you know, the more complex the lesion is, right, in terms of cost, potentially even cost savings. But let's say you have a straightforward, you know, mid-RCA 3-5 vessel. Is it really important to the imaging in a case like that?
Yeah, that's a good question. So, so at our hospital, we were originally with Nico Pels, very physiology minded. So it was, you know, almost everything was physiology and almost none of the imaging. So that's shifting a little bit over the past year. So with complex cases, with CTOs, and then we're using imaging much more. But I think for you know, the more simple lesion that you described, we use it rarely.
Rarely, okay. How about
oh, sorry. I just wanted to make one comment about the vulnerable plaque. So I think for the audience, it might be a bit confusing that we had, you know, the first talk was very optimistic about the vulnerable plaque, and then, you know, we have this great couple of Myers showing a difference, and then The second talk was also very impressive by Dr. Yang, that didn't show that optimistic approach for vulnerable plaques. So I think the difference between both talks is, I think the first talk focused primarily on patient level data, and while Dr. Yang's talk focused more on the vessel level or even more lesion level outcomes, which are probably more important if you want to treat, with a stent and treat a focal disease. So my question to the rest is it appropriate if we want to look for stents to look at non-lesion or non-culprit lesions, so outside of the target vessel?
Why do you want to look at it?
Yeah, so I'm also skeptical about the about performing PCI of those, what we call vulnerable lesions. I think there may be lesions that are vulnerable, but maybe more intense lipid lowering or PCSK9 inhibition, something like that, may be more appropriate for those patients.
So IK, let's take stenting off the table. In the search for the vulnerable plaque, as an astute physician, do you think that it could help with either insurance company approval, adding into algorithmic approach in the high-risk patient to change their lipid modification and their medical therapy? I mean, I think really that's where the major benefit is going to be.
So, Zia, when I started fellowship 35 years ago at this hospital, how we treated patients? Patient came in with acute MI. We tried diet, okay, which 100% fails. And then low dose something, cholesterol lowering. That's what we used to do because lack of understanding. And now, what do? Anybody comes in with any acute coronary syndrome, we hit hard first time. Rosuva 40 or Torva 80, max. And actually 3 weeks ago, I had a patient whose LDL was 3. We have now tools that we can manipulate LDL, right? So we don't play with this low dose nonsense, lipid lowering therapy. Anybody comes in with document, even people with stable angina, large plaque burden, I hit hard. If needed, down titrate, only when LDL is below 30. Otherwise, my target, not only mine, all my colleagues, 30, 40. That's our target. And what more can you do if you saw what you think is vulnerable? By the way, what I like to ask the panel is, what's the definition of vulnerable plaque? What do you call vulnerable plaque? Anybody knows?
Well,
we don't know.
Yeah, nobody knows, but I guess
Right.
The idea is a plaque that leads to an event. And the difficulty is which event matters. Unstable angina, MI, death, or all. Yeah,
hard endpoint. It's gotta be cardiac death or MI, some irreversible damage in the near future, not after 20 years, right? We don't have data. And also, as I tried
practical, but guys, from a practical standpoint, I completely agree with everybody saying here that we don't have enough evidence to put in stent somebody who has an FFR negative stenosis. There's no critical lesion and it's only vulnerable plaque on, let's say, OCT imaging. That's for sure. But I do think that we have enough evidence to say that if somebody gets a stent for a different lesion, and there is some features of plaque vulnerability, let's say proximal or distal of the stenosis, that already is going to be treated, to extend the stent such that to cover that, lipidic plaque, I think that makes sense from a practical perspective, and at least that's my practice, currently. I don't know if any of you guys.
Alan, is it to avoid stent edge dissection or is it to prevent future event? Your practice?
Kind of both. I mean, I don't want to put an edge of a stent in a vulnerable plaque because it leads to, I think it leads to higher rates of edge dissection and potential embolization. And second, yes, I think, if I can avoid a future event potentially by extending the stent another 10 millimeters, I think that's a reasonable trade-off.
I have one idea. So the based on the ischemia trial, a 5-year follow-up, the conservative treatment arms, the spontaneous MI risk rate is almost 10%. And conservative treatment arms, the spontaneous MI risk is around 5% at 5-year follow-up. So actually, so far, the vulnerable plaque study was done in the non-corporal region, less stenotic region. So I think we have to move to change our idea, our thought to the how to select the best target for stenting among the more tight and among the corporal region for stable angina.
All right, guys, maybe on that note, we should move on to the second part of the session, which is physiology. And we have 3 lectures coming up, and then we'll have another discussion later on. So why don't we get things started with Dr. An talking about the basics of physiology measurements, IFR, FFR, and the other non-hyperemic pressure ratios.
Okay, thank you. My topic is the basics of coronary physiology measurement, FFR, IFR, and other non-hyperemic pressure ratios. So we have many indices, non-invasive functional study, FFR, and IFR, and other non-hyperemic pressure ratios. Traditionally, we try to detect the objective ischemia to show the decrease of coronary blood flow by the perfusion imaging, stress echo, treadmill test. But in the cath lab, when we get this imaging stenosis, but we don't know whether this is truly functionally significant or not. So we need some this kind of non-invasive functional study in the cath lab. This is the idea of FFR. Nico Pals developed the FFR as a non-invasive functional study in the cath lab. This is the first, one of the first papers. Patient number is very small, but the cutoff value of 0.75 is very interesting. Look at less than 0.75, all lesions, at least one non-invasive functional study show positive. More than 0.75, the most lesions, non-invasive functional study negative. So predictive positive value is 100%. Negative predictive value is 88%. Very nice, very good positive and negative predictive value. Subsequent studies show that the cutoff value of FFR is located between 0.75 and 0.80. So FAME trial investigated the increased cutoff value to the 0.80. So the less than 0.80, FAME2 trial demonstrated that the stenting on the FFR less than 0.80 stenosis is associated with the low risk of urgent revascularization during the 5-year follow-up. But the FFR more than 0.80, stenting stenting has no clinical benefit over medical treatment. So FFR more than 0.80 should be different. Our Raji Iris FFR registry also supported the current contemporary cutoff value. We made the outcome drive the revascularization threshold. So regarding the cardiac death MI target vessel revascularization, blue line is hazard line of deferred lesion. Red line is hazard line of revascularized lesion. 2 lines intersected at the point of FFR 0.79. So very similar to the contemporary cutoff value of 0.80. More interestingly, regarding the cardiac death and MI, 2 lines intersected at the point of 0.64, very similar to the FAME2 trial mean FFR value. In addition, what is the benefit of FFR-guided PCI was demonstrated in the randomized trial. FAME1 trial randomized the FFR-guided PCI versus angio-guided PCI in the multivessel disease population. 1-year outcomes nicely demonstrated that the FFR-guided PCI reduced the clinical event MACE rate than the CAG-guided PCI. But during the 5-year follow, p-value became the non-significant, even though numerically FFR-guided PCI showed a low risk of MACE up to 5-year. More importantly, stent number reduced by 29%. How about the real-world registry data? Our Assam Medical Center PCI registry nicely demonstrated that the MACE rate compared with before routine use FFR, after routine use FFR, MACE rate is significantly reduced. Look at in detail of clinical benefit of FFR in the real-world registry. Stat number reduced by 29%. There is no difference regarding the death before and after routine use FFR. Myocardial infarction significantly reduced, but most reduction was done by the peri-procedural myocardial infarction, not spontaneous myocardial infarction. Repeat intervention also reduced significantly. Target vessel revascularization, target lesion revascularization. There is no sign of increasing in the new region revascularization. So I think major benefit of FFR-guided PCI is due to the reduced number of stents per patient and subsequent decreased risk of peri-procedural MI and repeat intervention, and maintaining favorable outcomes with a lesser stent implantation. So last year, two random trial published. Someone said it's a negative FFR trial, but I don't think so. This result is consistent with a previous random trial and registered data. Flower MI, even though the overall clinical outcome, there is no difference, but the stent number reduced by the 30% in FFR guided group. Even in the future trial, overall risk clinical outcomes, there is no difference, but in the FFR group, medical treatment proportion is significantly increased compared with the control groups. So those two groups also show the benefit of FFR-guided PCI. But the FFR showed a very important clinical benefit, but the FFR requires hyperemia. Hyperemia sometimes contraindicated or disliked by patient at cost and time inconvenient. So 2011, IFR concept was first reintroduced. The IFR 0.89 is best predictive of FFR 0.80. Subsequent to random trial, defined flare and IFR sweetheart trial nicely demonstrated that IFR is non-inferior to FFR to guide the revascularization decision. So currently, guideline endorsed both IFR and FFR recommendation 1A recommendation to assess the hemodynamic relevance of intermediate grade stenosis. I like to more. I think this sentence is more important. The stenosis with FFR more than 0.80, IFR more than 0.89, PCI should not be performed. I think this is more important than other sentence. Subsequently, we have many non-hyperemic pressure ratios. In addition, and FFR and resting PDPA, IFR and DPR, RFR and TFR. We evaluate such kind of non-hyperemic pressure ratios based on the ISFFR registry. Compared with FFR, the non-hyperemic pressure ratio accuracy rate is 80 to 85. But among the non-hyperemic pressure ratios, overall accuracy is 95%. Prediction of IFR less than 0.89. The AUC of resting PDPA, DPR, RFR, TFR is 0.97, 0.99, 0.99, 0.99. So I think overall identical. To predict clinical outcomes, resting PDPA, IFR, DPR, RFR, TFR showed a very similar Kaplan-Meier curve. So diagnostically, prognostically, all non-hyperemic pressure ratios showed identical, I think. But we have to know that there is 15 to 20% IFR, FFR discordant. What is the nature of discordant lesion? Regarding the physiology concept, FFR positive, IFR negative lesion, FFR negative and IFR positive discordant lesion, there is difference regarding the CFR. Regarding the anatomical concept, FFR is more strongly associated with adverse plaque characteristic. In addition, FFR positive, IFR negative group is usually focal stenosis. FFR negative, IFR positive is diffuse disease. So discordant lesion may have different physiologic and anatomical characteristics. How about the clinical characteristics? Discordant lesion is associated with the lesion location. So FFR positive non-hyperemic pressure negative lesion is associated with the proximal location, left main or proximal LAD, tighter lesion, looking angiographically more complex looking lesions. So how to compromise to discordant? I like to say the left main proximal LAD as a FFR zone, because in this region, anatomically more important, if we treat the, if we saw the, in this, if there is a stenosis, if the non-hyperemic pressure ratio is negative, to exclude the truly functional significant lesion. So I think we need hyperemia for left main or post-LAD stenosis. But the other location, distal lesion, small vessel, side branch lesion, non-hyperemic pressure ratio is enough. This is my summary. Current guideline widely endorsed the intracoronary physiology, both FFR and IFR. IFR could be used in revascularization decision-making, particularly when hyperemic agents are not easily available. FFR would be preferred in the lesion which was proximally located or showing angiography tight or complex. All non-hyperemic pressure ratios are the same. Physicians can apply other non-hyperemic pressure ratios in daily practice in the same manner as IFR. In the post-ischemia era, I think FFR positive or IFR positive would be minimum requirement for coronary revascularization. And stenting on stenosis with the FFR negative or IFR negative is never justified. Please differ. Thank you for your attention.
Thank you, Youngmin. Nice job. And next on deck, we have Bon-Kwon Koo, who does not need an introduction and is going to be discussing the imaging-based coronary physiology in clinical practice, looking at Ctffr and angio-FFR as a potential substitute for invasive measurements. Bon-Kwon?
Thank you, Alan. So almost 15 years ago in the cath lab, while measuring FFR in this kind of lesions, I thought about the possibility of measuring hemodynamics from images. So it's like measuring or calculating FFR without invasive procedure, without pressure wire, and without adenosine. So at that time, it was almost like a crazy idea. But now we are living in the abundance of image-based physiologic assessment from CT-derived FFR, angio-derived FFR, Ivis-derived FFR, OCT-derived FFR. So practically, I think that we can make FFR from any images. But today, my talk is about the Ctffr and angio-FFR. I'll talk about the brief concept and clinical data. So this is a prototype of the Ctffr, started with the three-dimensional anatomical model extracted from CT scan. And prototype used the supercomputer blood flow solution, but now there are several simpler models using 1D model, 2D model, so that it can be calculated with the laptop or the small computer. But anyway, with that blood flow solution, practically we can calculate or extract the CT-derived FFR at any part of the coronary circulation. So this is the basic concept of the Ctffr. So while working with the CT invasive angio, when we encounter the intermediate lesion, guideline directed us to measure FFR. So in the LAD lesion, FFR 0.74, which means that we have a green light for the PCI. But circumflex lesion, despite more severe stenosis, around 80% stenosis, 0.84. So general direction is to do a medical treatment. So Ctffr is almost risk-free, non-invasive, cost-saving pathology, a pathway, so that if we know that the FFR value with this non-invasive CT scan, we can simply do a PCI without measuring FFR. And for this circumflex RT, as FFR-CT is 0.85, if this number is reliable, we don't need to send the patient to the cath lab. and of course, no need of FFR measurement. So this is how this Ctffr, which is non-invasive physiologic assessment, can change the practice. But what about the diagnostic performance? There have been 3 pivotal clinical trials, comparison of Ctffr versus FFR, and the accuracy was around 80% with the sensitivity 90, specificity 72%. And there has been several additional clinical trials. So recently published meta-analysis show that the per patient and per vessel level sensitivity around 85 and specificity around 80. So some may be happy because this is a non-invasive test, but some may be unhappy with the around 80% accuracy. But among the gatekeepers or the non-invasive tests, Ctffr performed better than PET, SPECT, and of course CT anatomical sternal severity, so that this illustrates the goal of Ctffr in the gatekeeper for invasive procedures. So we recently presented the 10-year outcomes of Discover Flow study, which was presented in EuroPCI 2011, and we now have a 10-year outcome, and FFR-CT during 10 years was a significant predictor of the target vessel failure. Another very interesting concept to me as an interventional cardiologist is using a Ctffr technology or non-invasive technology as a treatment planning. So this rather complicated lesions, before we do any intervention, we can plan several different strategies like playing a computer game. So for these patients, my plan was to implant a left main to LAD stenting 3.0 around 80 millimeter stent and leaving that diagonal branch alone because of diffuse nature of that disease. So actually this was a live demonstration case. So I followed the decision made before the invasive procedure or live demonstration. And the predictive value after PCI in this case was 0.84, and during the live demonstration measured value was 0.85. It's so close. So it's interesting to see that kind of potential. So we did a first-in-human study for the validation of this treatment planner concept with the relatively small number. And recently, there has been an international multi-center study which compare the post-PCI invasive FFR versus FFR-CT, and the accuracy is quite good, so that this illustrates the potential of using this non-invasive technique as a kind of treatment planner. There has been a very interesting paper recently published for the using CT and Ctffr alone, planning and performing the bypass surgery. So for this almost 19-year lady, CT was performed, FFR-CT were calculated, and surgeon decided to do a mammary graft to LAD and 2 saphenous graft to RCA and obtuse marginal branches. And this is 1 month follow-up CT scan, which showed that relievement of ischemia in whole 3 circulation system. So it's interesting to see that this kind of possibility. And the other interesting part is angio-derived FFR. So we, as of now, 3 commercially available systems, QFR, FFR angio, VFFR. The mechanism is a little bit different, but basic concept is using angio to build a 3-dimensional reconstruction model. And QFR used the TIMI frame count to integrate the blood flow velocity, but the other used a different system. But anyway, with this combination with the mathematical calculation or the simulation, we can extract the angio FFR value. So several years ago, Dr. Collette reviewed the data and performed a study level meta-analysis using all different systems, and overall sensitivity and specificity numerically higher than Ctffr. It was around 90%. And one good thing is there was no difference according to a different software and different computational methods. One interesting comparison may be the comparison with the angio-derived FFR with the FFR, IFR, with the reference of PET-derived RFR, CFR, and CFC. So using RFR calculated by PET, FFR performed better than QFR, but when we use a CFR as a reference, all indices are the same. So that my personal bias is that the Q-FR is close to resting indices or the CFR rather than the FFR. One academically interesting question is, what will be the diagnostic performance comparison between the Q-FR and Ctffr? So this is another live demonstration case, and this 60% angiostenosis, plaque burden 76%, Q-FR measure 0.82, FFR-CT 0.86, measured FFR during the live demonstration was 0.85. And there was a study from Japanese colleague which showed that the performance of Q-FR is better than FFR-CT. I think it's due to the resolution of the images, but you have to understand that the Q-FR needs an invasive angio, and FFR-CT or CT-derived FFR does not need an invasive procedure at all. For the clinical outcomes, the weakness of angio-FFR or the Ctffr, it was that they didn't have a large randomized studies for the clinical outcome, but we know that the last year, Dr. Shubo presented and published the big randomized clinical studies which compared the Q-FR guided PCI versus angio guided PCI. So for the PCI eligible or planned patients, randomized into the Q-FR guided PCI, where the PCI was performed in 90%, and angio guided PCI practically 100% was PCI, and number of stents less, contrast less, fluoroscopic time less, procedure time net less, and residual functional syntax score less. And during the 1 year outcome, there was a difference, and angiographic guided was associated with the more risk of event in terms of MACE, and also even excluding a per procedure MI, Q-FR guided procedure was associated with the better outcome than angio guided PCI. So that there are several ongoing clinical trials, comparison Q-FR versus Ivis, etc., so that we will see more results in terms of clinical endpoint in a few years. One good thing of using this kind of image-based physiologic assessment is that all these are based on imaging, and we have a full 3D model, so we can do a very fine assessment in terms of for example, PPG is an index that is developed to assess the physiologically diffuse or local lesions, and it needs a automated pullback system to control the velocity of the pullback, but using angio-FFR, we don't need that kind of system. And when we make an algorithm, we can easily calculate this kind of PPG and simply divide the lesion according to the focality or diffuseness of the physiologic significance. And one interesting application of this angio-derived FFR is that the assessment of prognosis after PCI. There was a prospective Hawkeye study and retrospective analysis of Syntax-2 study, and both show that the post-PCI angio-derived FFR was associated with the prognostic implication, and low post-PCI FFR by angio was associated with the worst outcome. And it can also discriminate the location of the lesion, which made the low FFR or the low angio-FFR. So that I briefly mentioned the concept and current data about the angio and the CT-derived FFR, but I'm more interested in the future of image-based hemodynamic assessment, because it can be extended to the territory flow, microcirculation, and co-registration, plaque stress, etc. And for the Q-FR, which was the limitation was that we needed two separate angio images, but there was an advancement of the angio-FFR, so that I would say that the future is more promising than now for these image-based physiologic assessment. Thank you very much for your kind attention.
Thank you so much. And with that, let's move to the last talk of the session. Mort Kern is going to finish up with an update on the clinical conundrum. I didn't know we have a conundrum, but we're going to find out in a minute that we do. Mort?
Having me on your program. You know, I love this stuff, and I'm always delighted to participate, so I appreciate it. So Alan, we do actually have some conundrums, and I'm going to show you 5 of them in just a few minutes. The Dr. An and Dr. Koo set the stage beautifully for these discussions. So let me just, here are my disclosures. So let me, quickly to review, we do have a wonderful panoply of indices to use for physiology assessment. We started with hyperemic ratios. Actually, we started with PDPA, but after Grunsing, nobody liked to use that. But anyway, we have hyperemic pressure ratios. Those are FFR and submaximal contrast FFR. But people didn't like adenosine. There are lots of complaints, took some time and cost. And so we have more options. You don't like adenosine? Wonderful. Use the non-hyperemic pressure derived ratios, and they're listed here. They have thresholds that have been identified that correspond to FFR. And the issue with an ischemic gold standard still plagues us. So that is a conundrum that I'm not even going to discuss today. But let's look at a little bit of the 5 conundrums I thought were worthwhile, and I'll talk to you about potential solutions and some comments. So really, I've picked 5 general conundrums, difficulties that we face every day. So the first one is in a stable ischemic heart disease, when your NHPR is abnormal and your FFR is normal or non-ischemic and ischemic, what do? I picked left main plus downstream disease is another conundrum that we may have to face. This is important because not everybody enjoys stenting unprotected left mains. This also moves us to a quick discussion of serial lesions and couples with pullback data. Third conundrum is, how about that non-infarct artery in the ACS patient with a STEMI in another adjacent region? Can we trust that value of 0.85 at rest? How about the patient in whom we finished stenting? We have our pressure measurements distal to the stent. We look at our final number. Can we trust a number that's 0.84 in the distal segment to tell us that we're really done with our treatment of this artery? And lastly, I just want to briefly touch on the TAVR patient who has coronary disease. Can we use NHPR or FFR? Where do we find some problems, and what should our thinking be? So let me just take us through this in a few minutes. Conundrum number 1, not listed, is really our struggling to reconcile the visual image with our physiology and the mismatch between a tight lesion shown here and negative physiology on the right side. Now, given this is a really difficult example where your NHPR is cold normal, but your FFR approaches the borderline abnormality. And we'll see in just a second, this suggests very high flow across this lesion. Does it mean we should treat this? Because this discordance between the two is bothering us. Which indices do you trust most in this circumstance? And as we're going to see, you'll have to be a doctor to figure that out. So in discordant resting physiology, between that and hyperemic physiology, most of our problems occur around our cut points. And I think clinical data will suggest that it probably doesn't make much of a difference which of these 2 approaches we accept, whether it's positive or negative FFR or vice versa for that. It's the positives we have high confidence, and the negatives we have lower confidence. Now, the disparity often relates to high flow. I just showed you an example, we'll see more, but also to lesion characteristics and locations. And I was particularly interested in the conundrum that Dr. An pointed out, which is where the proximal zone seems to be FFR favorable and the distal zones NHPR favorable for usage. And we should probably discuss that in a little more detail. And then, of course, if you have technical errors, you're going to get discordant numbers. So let's just attend to that. I think it was important to recognize the fact that if you start at a normal IFR, as in the case I just showed, and you increase your coronary flow reserve 3 times, you can move into an abnormal FFR. And that does not necessarily indicate a severe lesion. It often indicates a mild lesion where we have to employ other clinical rationale. I don't think the defined flow study was definitive to say coronary flow reserve beats FFR values. So that's a subject of debate and a conundrum, as I'm pointing out. Certainly, if you have an abnormal IFR, it's pretty hard to get to a normal FFR, but there are some borderline values that will show up. So flow impacts the discordance. Now, nicely shown by Dr. An, that if you have patients who have diffuse disease, the pressure loss across such an artery is a function of the frictional coefficient to end flow, and in part to the separation coefficient to the quadratic of flow. But your negative FFRs and positive IFRs are more often associated with the diffuse disease process, as shown in the pullback tracing below. The converse is true for focal disease. Separation coefficient plays a greater role. There is more likely positive FFR and negative IFR. And the pullback tracing again shows that same focal disease. Warasar and colleagues put forth the percentages we might expect to see, where you have negative positive on the left, which is diffuse disease, more likely a positive IFR. And on the right, focal disease, less frequent, having more positive FFR. So keep it in mind when we're looking. Now, unfortunately, we're often stuck with mixed disease. So what do you do with this conundrum? Well, I think you need to have a stepwise approach to increase your level of confidence in decision-making. And then I think you need to employ clinical factors to make a decision about how aggressive you want to be. Is there microvascular disease? Did I exclude technical error to build my confidence? Let's turn our attention to left main with downstream disease. Here's a nice cartoon, 50% left main, 60% LAD. FFR is measured in the circumflex at 0.84. Is this an accurate number? And the issue hinges on how severe the LAD lesion is and how impaired the distal bed supplying the left main will be to determine the true FFR. If you look in this example, once we stented the LAD, the flow increased across the left main, and the FFR measured previously in the circuit 84 dropped to 74, meaning we probably need to treat that left main. How would we know this in advance? Well, Bill Fioran did the definitive study on informing us on what happens if we measure flow in two beds in a model that has a left main stent with a balloon in it to create a variable stenosis, and a second wire and balloon in the left main to create a similar variable stenosis. We set the left main at an intermediate lesion, and then we increase the stenosis in the left anterior descending. You see, as the severity of the LAD lesion increases, the FFR drops in the LAD, but it increases slightly in the circumflex. It goes from 0.77 to 0.82. So only if the LAD left main combined FFR is less than 0.6 do we worry about getting a false elevated left main FFR in the circumflex. Okay, so what happens in summary here? So for left main, we can use FFR without worrying about it. We can use IFR as well. There are some recent data that suggests that's fine, although that is a conundrum in itself, as Dr. Hahn pointed out. For distal left main bifurcation, certainly you can use FFR, both the LAD and the circumflex. If you have downstream disease, it's fine to use your FFR in the circ if the summed epicardial FFR is less than greater than 0.6. If it's less than 0.6, imaging is recommended. And finally, if the left main is measured only between the two lesions, LAD and left main, you're in a zone of potential false positive and probably shouldn't do that. Again, with serial lesions, this can be a problem no matter where those serial lesions are located. So for left main plus downstream disease, we talked about the threshold of the epicardial FFR when you use Ivis, and then I think you can use both to defer surgery when the values are normal. Let's turn to the ACS syndrome. You have an anterior infarct, you have disease in the adjacent circumflex and marginal branches. Your value is 0.85. Can you trust this? Well, I think you can trust this. Studies have shown these are pretty stable values over time. The one caveat is that if you're closer or very close to the infarct zone, you don't have a good appreciation whether the border zone is abnormal and will recover, or whether it will be stable and remain the same. One thing is true, if your FFR and IFR are positive in the non-culprit vessel, they're positive. You cannot get falsely abnormal values in those regions unless you have a technical error. But if they're negative, there is some thought that you should be considering whether this is a false negative because of the impaired myocardial bed in which this is measured. Here's the concept of the ACS and why we don't use it in the acute setting. Your myocardium is damaged at the moment of infarct. Your 75% stenosis registers a 0.84 FFR for whatever degree of flow you have. Your myocardium recovers over the next several days. Your 75% stenosis remains, but the flow to the myocardium has doubled, maybe, or increased substantially. And your FFR now, as predicted, would drop. So that's why the acute setting, or any setting in which your myocardium is impaired and then changes at a later time, like in collateralization, perhaps, you have to reassess the remaining lesion after the bed has stabilized. We know that in the acute coronary syndrome, coronary flow is impaired, FFR might be falsely high, IFR usually is stable. Now that's the one difference between the hyperemic and non-hyperemics. Autoregulation should maintain that flow. In the subacute recovery phase, CFR can increase, FFR may be the same, IFR may be the same, but as you enter into the stable convalescent period, CFR regains its basal state. With higher flow, FFR can drop, and IFR generally, again, stays pretty much the same. So there are some that advocate for the non-hyperemic ratios to assess these areas for elimination of more true values, or the use of more true values. Okay, so we've talked about ACS, higher confidence, away from the infarct zone, and if it's positive, it's positive. So I think we'll have more to discuss. How about post-Pci FFR? I'm speaking to an audience who does this and has produced the defined flow data, and we should take a look. Is a single point FFR valuable? And really, the coronary artery disease is predominantly more diffuse in many patients than purely focal, and thus a value downstream cannot be used as a single point. Who are you going to believe? Dr. Uretsky asks. So here I think is some really valuable data that points us in the direction we should be going when we talk about physiology of a vessel after stenting. We know many patients have residual ischemia. Alan did the defined PCI study. 20%, 25% have it, and of that 25%, 20% more is diffuse. Carlos Collette and his colleagues were able to now accurately define and really provide us with a quantitative estimate of how this works. The PPG index, disease over length, tells us that if you have a high number toward 1, you are dealing with predominantly a focal disease and a focal lesion. If your value is approaching 0, then you have very diffuse disease. The lower the number, the more diffuse, higher number, more focal. And then, of course, we have some mixed values. The outcomes of these, as Dr. Ahn pointed out, are certainly going to be revealing. And I believe the pullback methodology should be what we use routinely. So for single point FFR, I don't think we should be doing that. We should be doing pullback routinely if we want to know, are we finished with our stent implant? And of course, outcomes will validate this approach. Okay, lastly, let's look at the TAVR patient. This is just a quick scheme of what we think the physiology is doing with our TAVR patients. So initially, the aortic stenosis here produces an impaired coronary flow reserve due to subendocardial extravascular compression, hypertrophy, capillary density relative to mass, increased diffusion distance, and resting vasodilatation. Coronary flow reserve is impaired, fractional flow reserve might be high, and the basal flow is auto-regulated at whatever it is. So the IFR is stable. Now, after we do TAVR, that's the right scenario. We see coronary flow reserve tends to increase. With increased flow, FFR tends to decrease, and IFR is purportedly supposed to remain stable and be unchanged. And so will that be a more reliable number to assess lesions? So I just picked a recent study here that suggests that the changes in flow for both IFR and FFR before and after TAVR favor the resting ratio, as it does not change as much. If you look at the right-sided graph, you see that the pre-TAVR in blue, the post-TAVR in maroon. And for FFR, there's a drop, not a huge drop, but a 0.03 drop maybe on average, so that your FFR can become abnormal from the borderline zone. Whereas IFR, and even now I saw a paper on RFR, is more stable, or at least unfazed by the TAVR. So at the moment, I think that we see that there's less of a change of NHPR in the TAVR patient post-TAVR, and that this probably is an impactful way, although high trust is important because you don't want to go back through these valves stented, because they present a challenge both for engagement and for management. And again, the outcomes are depending on which of these two devices or which of these two methods we should use. Okay, with that set of conundrums, Alan, I hope I've given us enough food for thought to have some meaningful discussion. And I believe this will stimulate a lot of interest. Thank you very much.
Thanks, Mort. I guess you convinced me that there are still some open areas for discussion. You're right. So why don't we start with Dr. Matsuo? And let me ask, one of the issues that you brought up is non-culprit PCI in the setting of primary PCI, of course. And I think the data at this point, at least to my read, is pretty overwhelming that there is benefit, certainly against medical therapy. The question in that scenario is how much does physiology add? And the trials have not been so convincing, frankly, that the addition of physiology for the non-culprit assessment really made a difference, as opposed to just treating it with PCI. So I don't know what your practice is. I know you're using a good amount of physiology. Are you using physiology in the setting of non-culprit lesion assessment, and how do you use it from a practical standpoint?
Okay, your question is how we can apply the physiology to the ACS patients, to non-culprit region of the ACS patient, right? So
Exactly.
yes. In our practice, we definitely use the physiological assessment to the non-culprit regions, because of course, for our trial does not show the benefit of the FFR use for the non-culprit region. However, PCI itself, stenting itself, we can expect the relief of the pressure gradient of the lesion itself. So if we don't have any, how can I say, any pressure gradient in that region, we don't need to put the stent. It increases the risk of the stent disease, right? Therefore, in our practice, we definitely use the physiological assessment to the non-culprit regions.
If I
So
can
you're
add
a true believer.
some comments on that, I'm sorry to interrupt you. So that if I can add some comments on that, is that I think in that decision-making, anatomical stenosis severity matters, so that for example, complete trial showed the definite benefit of the complete revascularization, but in that trial, FFR usage was very small, but the average percent diameter stenosis was almost 80%. So if stenosis is severe, I think it's okay just to go a complete revascularization based angio. But if it is 60% stenosis, 50% stenosis, if the operators really want to do a PCI, it should be directed by either FFR or the non-hyperpressure ratio, so that as there's some uncertainty there, as Dr. Kuhn elegantly demonstrated, so that we have to understand that that cutoff should not be applied as they are in the stable coronary syndrome patients.
If I can ask just one quick question to the panel. So when non-culprit lesion had negative FFR or IFR, is there any role of OCT to look at the vulnerability? You know my answer, but I'd like to hear from you.
I don't think so. I think the imaging to the non-calprolific lesion, well, we can expect that many % of the lesions are very vulnerable. However, all we have to do is medical treatment, intensive lipid lowering therapy. That is, I believe, if the ischemia is negative in that regions, the intensive medical treatment, like the LDL cholesterol level less than 55 or something, is the best options for the treatment of such kind of the populations.
And Dr. Zimmerman, is that what you think?
Mort, last word, Mort, because I think we have to wrap it up slowly.
Yeah, I just say, I think imaging has a role for research in the non-culprit at the moment, but I don't, if it's physiologically negative, I don't know what your gain will be by imaging, but it would be very informative. I think that, complete revascularization should be still guided by physiology as you avoid stent disease if you can. And that's probably the only reason to use the physiology for this. Now, we had some contradictory data from the Flower study. I don't want to get into the weeds, but if the number's always positive, then there's no benefit demonstrated by FFR. That's what the Flower study told us. So you need to have a little different population to answer that question, I think, definitively. And it doesn't cancel out the value of FFR or IFR.
All right. So on that note, physiology is still important in clinical practice. It sounds like you guys are using it just as intravascular imaging. Thank you so much for a very, very informative and session. Great discussion. And join us for the next session on the TCT Asia Pacific. Thank you very much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye.
Bye-bye, everybody.
Bye.